I will be covering a topic that is very well known without boring you, and I'll be touching upon the main points. It is always found in the media. We see a metabolic syndrome article, and then it is in the psychiatry literature in the last 30 years, and after the medications are in use, this becomes one of the most important problems of our patients, metabolic syndrome for psychiatric patients and its relationship with psychotropic drugs. When we talk about metabolic syndrome, it is in fact a combination of 4 components: dyslipidemia, glucose intolerance, hypertension, and abdominal obesity. The syndrome is known since 1920s and has been named with different names like killing quartet, cardiometabolic syndrome, the insulin resistance syndrome, civilization syndrome, and World Health Organization brought its own criteria which were very well accepted, and there is an important factor which is insulin resistance that has to exist regardless. ATP3/3A, the updated version, identified criteria for insulin resistance and then the metabolic syndrome. And regarding metabolic syndrome, Turkish Endocrinology Society has a study group, and lastly they published a guide for this in 2005, and after 2005 no new criterion was brought forward and an update was not made, and there is an obesity study group which has published its own guideline, and these are all known to you. In fact, there is nothing new, and there are 5 main characteristics that we focus on: waist, blood pressure, HDL, triglycerides, and fasting glucose levels. Waist circumference, and International Diabetes Federation thinks that for men 94 should be the limit, for women 80. ATP on the other hand allows until 102 for men, 88 for women, and blood pressure is as follows. However, under antihypertensives, even if it's normal, we take it as a criterion. In men below 40, in females below 50, HDL is important, and above 100 is a criterion for metabolic syndrome. And waist should always be included as a criterion, and there should be additional 2 criteria adding to the waist. We talked about 2004-2005 and the guidelines that were published. After these guidelines, they say that if there is no such thing as metabolic syndrome, American Diabetes Association and European Association made a joint declaration saying that this might not be a real syndrome, and when providing justifications they said that there is a lack of clarity of definition, and there are multiple different phenotypes, and lack of a consistent evidence-based setting for thresholds they mentioned, and there is no pathogenesis that would bring together these parameters. There are other cardiovascular risk factors that have not been mentioned. When we take the components separately or take them jointly, the risk doesn't increase, they said. So we should keep this dimension in mind as well. Whether it be a superficial syndrome, this is something that has been defined for the last 100 years. Atypical antipsychotics are important risk factors for these, because the risk for metabolic syndrome increases 2 to 4 folds by the use of these medications. And there is weight gain and fasting triglyceride, cholesterol, and glucose levels are altered, and when compared with controls, we see a significant difference in those parameters upon the use of antipsychotics. However, antipsychotics are rendered scapegoats on the other hand. In a prevalence study in the US, even though antipsychotics were not used, after the age of 20, 27% of the population has metabolic syndrome, and Turkish Endocrine Society conducted a similar study, finding the rate as 34%. And this bases 102 centimeters of waist in males, 88 centimeters in females. If it had been shorter or lower, the rates would have been higher. From this perspective, nearly 1 out of 3 individuals have metabolic syndrome regardless of using antipsychotics. And my colleague Sermin mentioned about bipolar disorders and schizophrenia, and in terms of their pathogenesis, they might result in metabolic syndrome. Before using any medications, when schizophrenia patients come to you, you see the increase in the visceral adipose tissue. Visceral adipose tissue is the fat accumulation around internal organs, and these patients had threefold increase in this tissue, although they did not use any antipsychotics. And in insulin resistance, we see that there is a higher incidence of resistance in patients even before using antipsychotics. In that regard, I will be talking about the components of the metabolic syndrome, not the syndrome itself. I think that this will be more relevant. Weight gain. We will be talking about clozapine. And clozapine for metabolic syndrome is a very risky molecule. However, on the other hand, when we are to look at the criteria in drug-resistant cases, this is a medication we should definitely use. On one hand, we are trying to treat the patient. On the other hand, we might be creating several risks, or the patient is being confronted with several risks. And in different studies, weight gain was not related to the dosage of the medication. And the weight gain starts after 4 weeks, and between 4 to 12 weeks it continues, and it plateaus after 12 weeks. And with olanzapine and clozapine, this might last longer. Let me touch upon the underlying mechanisms. Dopamine is a molecule that decreases the appetite, and that exerts its effect through the lateral hypothalamus. And olanzapine using patients were given amantadine, and amantadine could prevent the weight gain, and the patients could shed weight, in fact. And H1 and H3 receptors are also related to weight gain, together with GABA glutamate dysfunction. And clozapine resulted in 20% weight gain in 1/3 of the patients. And these patients were followed up, and nearly 50% of these patients continued to gain weight. And clozapine also increases leptin. Leptin normally is an anorexic agent, and despite leptin levels were high, clozapine resulted in weight gain, which was explained through leptin resistance.
Evet, şimdi kısaca glukoz metabolizmasına.
Let us touch upon the glucose metabolism briefly. When we are to compare with typical and non-typical drugs, we see that there is increased risk of diabetes, type 2 diabetes in atypicals. And certain antipsychotics are not in this list, though. When we are to look at schizophrenia patients, we see that 45% of the patients are diagnosed as diabetes within the first 3 months, and 50% had a positive family history of diabetes. Those who were diagnosed with diabetes, 50% of these did not have any weight gain. However, they had diabetes. The result is that atypical antipsychotics have a diabetogenic effect regardless of, independent of weight gain, and might result in insulin metabolism abnormalities. How do they have this direct effect? Through 5-HT antagonism, insulin sensitivity is decreased, which means insulin can no longer transport glucose into the striated muscle, which means blood sugar is elevated. And clozapine and olanzapine were given intraperitoneally in mice, and acutely both serum glucose and free fatty acids were shown to increase. In the pancreatic Langerhans islets, they have direct negative effects, and growth hormone and insulin-like growth factor were affected, and these hormones were affected, resulting in an insulin resistance, it was said. In follow-up studies, after the treatment with clozapine was stopped, 46% of the patients improved, and 62% did not have any need for hypoglycemic agents. I have the full text of all these studies, but I wanted to give you the punchlines. If you want to have the detailed articles, I might share them after the presentation. In a 26-week follow-up study with ariprazole, we see that there isn't any change in fasting glucose levels, and there is no clue of diabetogenic effect in ziprasidone. FDA, as you know, warns about diabetes and antipsychotic medication, and says that antipsychotic medications result in hyperglycemia and diabetes, and they have such a risk, they say. And this is given as an insert info. What was our other criteria? Dyslipidemia. Dyslipidemia is seen between 40 and 120 days of usage in antipsychotics. It starts decreasing after this, however, it never comes back to its normal levels. And LDL cholesterol levels were found high with clozapine and olanzapine. And olanzapine increases the risk with 5 times and typicals 3 times. Dyslipidemia was shown in 40 to 60% of patients using clozapine. There was no risk of dyslipidemia with risperidone, ariprazole, sertindole, and ziprasidone. Another dimension is hypertension. Hypertension is not related with any antipsychotics than clozapine. 27% of patients using clozapine needed antihypertensives in the long run. And this is the American Diabetes Association guideline. Here you see that both in weight gain and diabetes, clozapine and olanzapine come first and second, as well as hyperlipidemia. But regarding diabetes and hyperlipidemia for other medications, the data is quite inconsistent. Let me briefly touch upon how to follow up these patients. When the patient first comes, we check the baseline levels. Afterwards, on the first month, third month, and every 3 months, we check the body mass index. This is also true for the waist circumference. Blood glucose when the person first arrives, and every 3 months. HDL when the person first arrives at the first month, third month, and every 3 months. Same is true for triglycerides And blood pressure is also important. It should be measured when the patient first comes and on the third month, 6th month. And it can be expressed on a weekly basis as well, if you like to work with weeks than months. I don't want to bore you with any further details, but the treatment of metabolic syndrome has two aims. One is to treat the underlying causes, the second is to treat the cardiovascular risk factors. This requires lifestyle management. Somehow the lifestyle of the patient should be handled, and this requires a multimodal approach including diet, exercise and pharmacological therapy. And 45 to 60 minutes of activity is suggested. However, this is for patients who have metabolic syndrome but not psychiatric disease. For our patients, it is as much as the patient can do. We suggest 3 times a week and 10,000 steps a day. And if the patient can lose 5 to 10% of his or her weight in 3 to 6 months, we can control all the criteria for metabolic syndrome. For weight loss, we have orlistat, which is recommended for patients who have a body mass index of more than 40. Metformin is a good medication. It can be used. However, it should be used together with a consultation of an endocrinology specialist. It improves insulin resistance and can correct dyslipidemia. Regarding metformin, creatinine level is important. If patients have a creatinine level of 1.4 or above, it might result in lactic acidosis, and if there is kidney failure, it might not be the appropriate choice. Glitazones are not to be used during cardiac failure. Fibrates decrease serum triglycerides. Statins lower LDL. Exercise and quitting smoking can be of importance for increasing HDL levels. For hypertension, salt restriction is important, and we have to initiate the correct antihypertensives. ACE inhibitors and angiotensin II receptor antagonists are advocated. In addition to regulating the blood pressure, they increase insulin sensitivity and prevent diabetes. They at the same time have cardioprotective and renoprotective effects. Let me conclude my presentation like this. We can come to the details in the question and answer session. Thank you very much.